Welcome to our video on acid-base disorders. In this video, you will learn how to analyze acid-base disorders based on a basic chemistry panel and an arterial or venous blood gas. In analyzing acid-base disorders, we need to obtain a basic chemistry panel and a blood gas. Before we proceed to analyzing our data, we need to make sure the chemistry and the blood gas were obtained at the same time and are internally consistent. Changes in a patient's condition can occur quickly. A chemistry panel obtained in the morning and a blood gas obtained in the evening may reflect different acid-base disorders, as the patient's condition may change with time. Clinically, we can more or less be assured that the chemistry panel and blood gas are internally consistent by comparing the serum bicarbonate from the two sources. The bicarbonate levels from these two sources should be within 2 units of each other. If they differ by more than 2, it is best to repeat both the chemistry and blood gas. Alternatively, we can calculate the blood pH based on the serum bicarbonate from the chemistry and partial pressure of carbon dioxide, or PCO2, from the blood gas using the Henderson-Hasselbalch equation. The calculated pH should match the pH from the blood gas. Next, we need to familiarize ourselves with basic normal values. Normal pH is 7.4. Normal PCO2 from an arterial blood gas, or ABG, is 40. Serum bicarbonate is 24, and serum anion gap is 12. Because it is painful to stick an artery to get an ABG, we commonly obtain a VBG from a venous blood draw and convert it to an ABG. On this slide, we have equations that help convert values from a VBG to an ABG. ABG pH is VBG pH plus 0.03. ABG PCO2 is VBG PCO2 minus 4. And ABG bicarbonate is VBG bicarbonate minus 1. There are more than one way to analyze acid-base disorders. This is particularly true in the first step. Some people look at the serum bicarbonate first, some look at the pH, others look at the PCO2. Our approach is to first check serum bicarbonate from the chemistry panel. If the serum bicarbonate is low, that is, if it is less than 24, then we know we have two possible disorders: metabolic acidosis or respiratory alkalosis with compensation. The latter because when there is a respiratory alkalosis, the kidneys correct the alkalemia by decreasing the serum bicarbonate. If the serum bicarbonate is greater than 24, then we have either metabolic alkalosis or respiratory acidosis with compensation. The latter because when there is respiratory acidosis, the kidneys correct the acidemia by increasing the serum bicarbonate. Note, we differentiate our respiratory processes as acute or chronic. The reason for this is because it takes the kidneys longer to fully compensate and readjust the serum bicarbonate to a respiratory disorder than for the lungs to compensate and readjust PCO2 to a metabolic disorder. Acutely, the kidneys can only compensate so much, but if more time is allowed, i.e. in a chronic respiratory process, defined as occurring over 48 hours or longer, the kidneys should then be expected to fully compensate. Moving on, how do we choose which of the two possible disorders a patient may have? We check the pH to decide on the first most likely acid-base disorder. For example, if we have a high serum bicarbonate or serum bicarbonate above 24 and the pH is greater than 7.4, we are safe to guess that the first acid-base disorder is metabolic alkalosis, because if we had a respiratory acidosis, we would expect the pH to be less than 7.4. Another example, if we have a serum bicarbonate less than 24 and a pH greater than 7.4, we are safe to say that the first acid-base disorder is a respiratory alkalosis with renal compensation, because if we had a metabolic acidosis, we would expect the pH to be less than 7.4. Moving on. How do we determine if our patient also has another concurrent acid-base disorder? Well, for any primary acid-base disorder, we know exactly how much the lungs and kidneys are supposed to compensate. That is, if we have a primary metabolic acidosis where the serum bicarbonate drops, we can expect exactly how much the lungs will drop the PCO2 level by to maintain relatively normal blood pH. If the actual PCO2 is not as expected, then we can deduce that there is a second acid-base disorder. Similarly, if we have a primary respiratory acidosis where the PCO2 increases, we can expect exactly how much the kidneys will increase the serum bicarbonate by to maintain relatively normal blood pH. If the actual serum bicarbonate does not match what is expected, then we can deduce that there is a second acid-base disorder. Compensation factors for acid-base disturbances are as follows. For metabolic acidosis, for every 1 drop in serum bicarbonate, PCO2 also drops by 1. Example, if we have a patient with a serum bicarbonate of 18, the serum bicarbonate drops by 6 from the normal 24. This means the normal PCO2 of 40 should also drop by 6. We would therefore expect this patient's PCO2 to be 40 minus 6, or 34. It must be noted, however, that the calculated expected PCO2 is not an exact value, but rather a value within an error margin of plus or minus 3. In this particular example, the expected PCO2 is not exactly 34, but rather ranges between 31 and 37. What do we do with this calculated expected PCO2 range? We compare it to the actual PCO2 obtained from the blood gas. Example, let's say the measured PCO2 is 42 for our current example of metabolic acidosis, where the serum bicarbonate is 18 and the expected PCO2 is 34 plus or minus 3. 42 is greater than our expected value of 34 plus or minus 3. So we can deduce that the lungs cannot fully ventilate to bring the PCO2 down to our expectation. This means there is also a problem with the lungs, or there is also a concurrent respiratory acidosis. What if the measured PCO2 is 27 in this example? 27 is lower than our expected value of 34 plus or minus 3. We can deduce that the lungs ventilate a lot more than expected because more CO2 has been blown off than expected. This means, for whatever reason, there is also a concurrent respiratory alkalosis. By comparing an actual measured value to an expected value, we can spot the presence of an additional acid-base process when the actual value does not match with the expected value. Moving on. For metabolic alkalosis, for every 1 increase in serum bicarbonate, PCO2 increases by 0.7. Example, for metabolic alkalosis with a serum bicarbonate of 30, serum bicarbonate increased by 6 from the normal bicarb of 24. Since for every 1 increase in serum bicarbonate, PCO2 increases by 0.7, we multiply 6 by 0.7, which gives us 4.2. We add 4.2 to the normal PCO2 of 40 because PCO2 is supposed to go up when bicarbonate goes up. This gives us an expected PCO2 of approximately 44. What do we do with this calculated expected PCO2 range? We compare it to the actual PCO2 obtained from the blood gas. Example, let's say the measured PCO2 is 52. 52 is greater than our expected value of 44 plus or minus 3. We can deduce that the lungs cannot fully ventilate to bring the PCO2 down to our expectation. This means there is also a problem with the lungs, or there is also a concurrent respiratory acidosis. What if the measured PCO2 is 32? 32 is lower than our expected value of 44 plus or minus 3. We can deduce that the lungs ventilate a lot more than expected because more CO2 has been blown off than expected. This means, for whatever reason, there is also a concurrent respiratory alkalosis. By comparing an actual measured value to an expected value, we can spot the presence of an additional acid-base process when the actual value does not match the expected value. When we talk about a metabolic process such as metabolic acidosis or alkalosis, the lungs can compensate quickly, so our PCO2 compensation factor is just a simple number. For a respiratory disturbance, however, the kidneys take time to fully compensate. For that reason, renal bicarbonate compensation factors for a respiratory process are divided into an acute and chronic phase. Acute is defined as occurring in less than 48 hours and chronic in greater than 48 hours. For acute respiratory acidosis, for every 1 increase in PCO2, serum bicarbonate increases by 0.1. Example, a patient with acute respiratory acidosis with an increased PCO2 of 48. This means the PCO2 increased by 8 from the normal 40. Since for every 1 increase in PCO2, bicarbonate increases by 0.1, we multiply 8 by 0.1. This gives us 0.8. When PCO2 goes up in respiratory acidosis, bicarbonate also goes up, so we add 0.8 to 24. This gives us an expected serum bicarbonate of approximately 25. For expected serum bicarbonate, the margin of error is plus or minus 2. For chronic respiratory acidosis, for every 1 increase in PCO2, serum bicarbonate increases by 0.4. Example, a patient with chronic respiratory acidosis with a PCO2 of 60. This means the PCO2 increased by 20 from the normal 40. Since for every 1 increase in PCO2, bicarbonate increases by 0.4, we multiply 20 by 0.4. This gives us 8. When PCO2 goes up in respiratory acidosis, bicarbonate also goes up. So we add 8 to 24. This gives us an expected serum bicarbonate of approximately 32. How do we determine if there is another acid-base process in addition to a primary respiratory acidosis? We first calculate the expected serum bicarbonate for both acute and chronic respiratory acidosis, then compare it to the actual serum bicarbonate. Example, a patient with respiratory acidosis where the PCO2 is 67. For acute respiratory acidosis, the expected bicarbonate is 24 plus the quantity 67 minus 40 times 0.1, which is equal to the range of 25 to 29. For chronic respiratory acidosis, the expected bicarbonate is 24 plus the quantity 67 minus 40 times 0.4, which is equal to a range of 33 to 37. The expected bicarbonate range from acute to chronic respiratory acidosis is therefore 25 to 37. We then compare the expected bicarbonate range to the actual serum bicarbonate. If this same patient's actual bicarbonate is closer in value to 25, we can assume that the patient has an acute respiratory acidosis. If the serum bicarbonate is closer to 37, then we can assume that the patient has a chronic respiratory acidosis. However, when the actual serum bicarbonate is outside the range of 25 to 37, it means that the patient also has another process other than the current respiratory acidosis. For example, if the actual serum bicarbonate is less than 25, then we can assume that the patient also has a metabolic acidosis. And if the actual serum bicarbonate is greater than 37, then we can say that the patient also has a metabolic alkalosis. Moving on. For acute respiratory alkalosis, for every 1 decrease in PCO2, serum bicarbonate decreases by 0.1. Example. A patient with acute respiratory alkalosis with a decreased PCO2 of 30. This means the PCO2 decreased by 10 from the normal 40. Since for every 1 decrease in PCO2, bicarbonate decreases by 0.1, we multiply 10 by 0.1. This gives us 1. When PCO2 goes down in respiratory alkalosis, bicarbonate also goes down, so we subtract 1 from 24. This gives us an expected serum bicarbonate of approximately 23. For chronic respiratory alkalosis, for every 1 decrease in PCO2, serum bicarbonate decreases by 0.5. Example, a patient with chronic respiratory alkalosis with a PCO2 of 30. This means the PCO2 decreased by 10 from the normal 40. Since for every decrease of 1 in PCO2, bicarbonate decreases by 0.5, we multiply 10 by 0.5. This gives us 5. When PCO2 goes down in respiratory alkalosis, bicarbonate also goes down, so we subtract 5 from 24. This gives us an expected serum bicarbonate of approximately 19. How do we determine if there is another acid-base process in addition to a primary respiratory alkalosis? We first calculate the expected serum bicarbonate for both acute and chronic respiratory alkalosis, then compare it to the actual serum bicarbonate. Example, a patient with respiratory alkalosis where the PCO2 is 27. For acute respiratory alkalosis, the expected bicarbonate is 24 minus the quantity 40 minus 27 times 0.1, or the range of 21 to 25. For chronic respiratory alkalosis, the expected bicarb is 24 minus the quantity 40 minus 27 times 0.5, or the range of 16 to 20. The expected bicarbonate range from acute to chronic respiratory alkalosis is 25 to 16. We then compare expected bicarbonate range to the actual serum bicarbonate. If the patient's actual bicarbonate is closer in value to 25, we can assume that the patient has an acute respiratory alkalosis. If the serum bicarbonate is closer to 16, then we can assume that the patient has a chronic respiratory alkalosis. However, when the actual serum bicarbonate is outside the range of 25 to 16, it means that the patient also has another process other than the current respiratory alkalosis. For example, if the actual serum bicarbonate is less than 16, we can assume that the patient also has a metabolic acidosis. And if the actual serum bicarbonate is greater than 25, we can assume that the patient also has a metabolic alkalosis. Compensation factors actually vary slightly in the literature, as you can see a range here. For simplicity, we can just use these numbers and determine acid-base disorders. Overall, if we add a margin error of plus or minus 2 in the calculation of expected bicarbonate and plus or minus 3 for expected PCO2, our results will be relatively accurate. For severe metabolic acidosis or alkalosis, Winter's formulas may be used instead of compensation factors provided in the table above for better accuracy. For metabolic acidosis, the expected PCO2 can be calculated as 1.5 times bicarbonate plus 8 plus or minus 2. For metabolic alkalosis, the expected PCO2 may be calculated as 0.7 times bicarbonate plus 20 plus or minus 5. Let's quickly review the steps we've gone through thus far in analyzing acid-base disorders. Step 1. Check serum bicarbonate. Is it below 24 or above 24? Based on the serum bicarbonate, we can determine two possible acid-base processes. Note that the two processes are opposite in terms of their effect on blood pH. One is an acidosis and the other is an alkalosis. How do we know which of the two processes we may have? Step 2. Check pH from the blood gas to determine if the acidosis or the alkalosis is more likely. This step narrows down the most likely primary acid-base process. Once we decide on the primary acid-base process, we go to step 3, where we calculate compensation for the primary acid-base process. If the expected serum bicarbonate or PCO2 does not match with its actual value, we know that there is another problem. This step allows us to spot an additional acid-base process if it exists. It turns out that some patients can have 3 different acid-base disorders going on simultaneously. This leads us to our 4th step, checking the serum anion gap. What is a serum anion gap? We start with the concept that the number of positive charges is equal to the number of negative charges in the body. Basically, the number of positive charges from positively charged molecules such as sodium and other unmeasured cations should add up to equal the number of negative charges from negatively charged molecules such as chloride, bicarbonate, and unmeasured anions in the blood. Since we routinely measure serum sodium chloride and bicarbonate in the blood, we rearrange the equation and put all of them on one side of the equation and the unmeasured anions and cations on the other side of the equation. This entity of the difference of unmeasured anions and cations in the blood is referred to as serum anion gap. The serum anion gap is typically 12 plus or minus 2 millimoles per liter in individuals with normal blood tests. Serum anion gap that is outside of the normal range may be seen in various conditions as shown here. Common conditions that give rise to a low serum anion gap includes hypoalbuminemia and paraproteinemia as seen in multiple myeloma. Note that for hypoalbuminemia, the serum anion gap is expected to drop by 2.5 for every 1 drop in serum albumin level from normal. For example, given a normal serum albumin of 4.5, a patient with a serum albumin of 2 would have approximately 4 drop in the serum anion gap, or corrected serum anion gap of 12 minus 4, or 8. If this particular patient presents with a gap of 12, the patient would be considered to have an elevated serum anion gap. It is prudent to always calculate corrected serum anion gap for patients with low serum albumin. Some patients can have an elevated serum anion gap from a metabolic acidosis where the acid is accompanied by an anion, such as lactate with lactic acidosis, salicylate with salicylic acid, etc. So how do we use serum anion gap to look for another acid-base process? When we see an elevated serum anion gap, we can generally assume that there is a metabolic acidosis where the accompanying anion causes the increase in serum anion gap. Let's take a look at an example where a patient has a serum anion gap of 21 instead of the normal 12. When we have a serum anion gap of 21, we can assume that in addition to the normal 12 anion gap, we now have 9 extra anions. We can next assume that these 9 anions must have accompanied 9 equivalent acid or H+. We next assume that for every acid, 1 bicarbonate will be used to neutralize the acid. In this case, 9 bicarbonate will be consumed. Normally, we have 24 bicarbonate. Now, if we use up 9 bicarbonate to neutralize 9 acids, we will have 24 minus 9, or 15 bicarbonate left. Basically, based on the 9 acids that we have deduced from the 9 anions that we picked up from the increased anion gap, we can calculate our expected serum bicarbonate. Let's do another case with high serum anion gap. Imagine a patient with a chemistry panel as shown. The serum anion gap for this patient is 142 sodium minus 92 chloride minus 23 bicarbonate, which is 27. When we have a serum anion gap of 27, we can assume that in addition to the normal 12 anion gap, we now have 15 extra anions. We can next assume that these 15 anions must have accompanied 15 equivalent acid, H+. We next assume that for every acid, 1 bicarbonate will be used to neutralize the acid. In this case, 15 bicarbonate will be consumed. Normally, we have 24 bicarbonate. Now, if we use 15 bicarbonate to neutralize 15 acids, we will have 24 minus 15, or 9 bicarbonate left. Basically, based on the 15 acids that we have, deduced from the 15 anions that we picked up from the increased anion gap, we can calculate our expected bicarbonate. What we do next is to compare this expected bicarbonate to the actual measured serum bicarbonate. In this case, the actual serum bicarbonate is 23. 23 is greater than 9. This means there are actually more bicarbonate in the blood than we expect if we just had an elevated anion gap metabolic acidosis that used up its equivalent bicarbonate. These extra bicarbonate suggest that there is another process that causes an increase in serum bicarbonate. A process that can cause an increase in serum bicarbonate is metabolic alkalosis. Bottom line, when we have a measured serum bicarbonate that is greater than the expected bicarbonate, we can deduce that in addition to the high serum anion gap metabolic acidosis that we recognize, we also have a concurrent metabolic alkalosis. Let's do another case of high serum anion gap metabolic acidosis where the serum anion gap is 19. For a serum anion gap of 19, we have the normal 12 anion gap and 7 extra anions. The 7 extra anions can be translated as having an equivalent of 7 acids that consume 7 bicarbonate to give an expected serum bicarbonate of 17. Again, we compare the expected bicarbonate to the measured bicarbonate. In this case, The actual measured serum bicarbonate is only 5, which is much lower than what we expect. We expect to see 17 bicarbonate, but we only see 5 actual bicarbonate. What does this mean? It means that there must be another metabolic acidosis that uses up bicarbonate, but not having an accompanying anion for us to detect in the serum anion gap. This means we must also have a normal anion gap metabolic acidosis. Bottom line, when the actual serum bicarbonate is much lower than the expected bicarbonate, we can deduce that there must also be a normal anion gap metabolic acidosis present. Can we have a patient who has both an elevated anion gap metabolic acidosis and a normal anion gap metabolic acidosis? Of course. Look at the differential diagnoses of normal and elevated serum anion gap metabolic acidosis. A patient can have a normal serum anion gap metabolic acidosis from having diarrhea, while being septic with a high serum anion gap metabolic acidosis from lactic acidosis. A patient can have any of the processes that present as a normal serum anion gap metabolic acidosis, in addition to having a condition that presents as an elevated serum anion gap metabolic acidosis. There's nothing that would prohibit a patient from having more than one process concurrently. Let's review the utility of calculating a serum anion gap. An elevated anion gap gives us an idea of how many HA acids are present in the body. Assuming that every acid uses up a serum bicarbonate, we calculate the expected serum bicarbonate. We then compare this expected bicarbonate to the actual bicarbonate from the chemistry panel. Based on the difference, we can deduce the presence of another acid-base process, if any. If the actual serum bicarbonate is within the range of the calculated expected bicarbonate, there is no additional acid-base disorder. If the actual serum bicarbonate is greater than the expected bicarbonate, we can assume that there is a concurrent metabolic alkalosis. If the actual serum bicarbonate is lower than the expected bicarbonate, we can assume that there is a concurrent normal serum anion gap metabolic acidosis. Let's summarize how we analyze acid-base disorders. First, make sure there is internal consistency. Clinically, we can do this by noting that the serum bicarbonate from the chemistry panel and blood gas are within 2 units of each other. If they are vastly different, send for a new set of labs. Once we confirm internal consistency, we can proceed to analyzing acid-base disorders. Step 1. Check serum bicarbonate to narrow down the first 2 possible acid-base disorders. Step 2. Check the pH to determine which of the 2 possible acid-base disorders is most likely. Step 3. Check compensation to determine if a second acid-base process is also present. Step 4. Check the serum anion gap to calculate the expected serum bicarbonate. Compare this expected bicarbonate to the actual serum bicarbonate from the chemistry panel. If these two are not within 2 units of each other, we can deduce that there is another acid-base disorder present. Let's do some practice problems. We have a 30-year-old female who presents with progressive fatigue. Her chemistry panel and ABG are as shown. Pause the video if you want to try to do this problem yourself first. Step 1. Check serum bicarbonate. It is 14, which is low. This means patient may have a metabolic acidosis or respiratory alkalosis with renal compensation. Step 2. Check pH. pH is less than 7.4, which is low. This means the most likely disorder is a metabolic acidosis. Step 3. Check compensation. For metabolic acidosis, every 1 drop in bicarbonate would result in a 1 drop of PCO2. Since the serum bicarbonate drops from the normal 24 to 14, or a drop of 10, PCO2 should also drop by 10. The expected PCO2 is therefore 40 minus 10, or 30, plus or minus an error margin of 3. Comparing the expected PCO2 to the actual PCO2 of 28. 28 is within the range of 30 plus or minus 3, so we are good here. No hidden second process. Step 4. Calculate serum anion gap. It is 21, which means we have the normal 12 anion gap plus 9 extra anions or acids around. The 9 acids are expected to consume 9 bicarbonate. The expected bicarbonate would therefore be 24 minus 9, or 15 plus or minus an error margin of 2. Comparing this expected bicarbonate of 15 to the actual bicarbonate of 14. 14 is within the range of 15 plus or minus 2, so we do not have another acid-base disorder. Final answer. Because the serum anion gap is 21, which is considered high, because normal serum anion gap is 12 plus or minus 2, we can say patient has a high anion gap, metabolic acidosis. In this case, the high gap metabolic acidosis is most likely from uremia, given that patient has a blood urea nitrogen of 100 and creatinine of 10. This is the case of a 29-year-old male with a history of hypertension who presents with the following chemistry and ABG. Step 1. Check serum bicarbonate. It is 32, which is high. This means patient may have a metabolic alkalosis or respiratory acidosis with renal compensation. Step 2. Check pH. pH is greater than 7.4. This means the most likely disorder is metabolic alkalosis. Step 3. Check compensation. For metabolic alkalosis, every 1 increase in bicarbonate would result in an increase of 0.7 in PCO2. Since serum bicarbonate increases from the normal 24 to 32, or an increase of 8, PCO2 should increase by 8 times 0.7, or 5.6, or approximately 6. The expected PCO2 is therefore 40 plus 6, or 46 plus or minus 3. Comparing the expected PCO2 to actual PCO2 of 44. 44 is within 46 plus or minus 3, so we are good here. No hidden second process. Step 4. Calculate serum anion gap. It is 13, which is within the normal serum anion gap range. There is no other hidden process. Final answer, patient has metabolic alkalosis. Given the concurrent triad of hypertension, metabolic alkalosis, and hypokalemia, we must consider the possibility of a high mineralocorticoid state, such as adrenal hyperplasia or adenoma, or hypercortisolism, such as Cushing disease or syndrome. This is the case of a 67-year-old male with chronic back pain who presents with dizziness, unsteady gait, and tinnitus. Step 1. Check serum bicarbonate. It is 12, which is low. This means patient may have a metabolic acidosis or respiratory alkalosis with renal compensation. Step 2. Check pH. pH is less than 7.4. This means the most likely disorder is metabolic acidosis. Step 3. Check compensation. For metabolic acidosis, every 1 drop in bicarbonate would result in a drop of 1 in PCO2. Since the serum bicarbonate drops from the normal 24 to 12, or a drop of 12, PCO2 should also drop by 12. The expected PCO2 is therefore 40 minus 12, or 28 plus or minus 3. Comparing the expected PCO2 to actual PCO2 of 22. 22 is much lower than 28 plus or minus 3. This means we also have a respiratory alkalosis. Step 4. Calculate serum anion gap. It is 24, which means we have 24 minus 12, or 12 extra anions or acids around. The 12 acids are expected to consume 12 bicarbonate. The expected bicarbonate would therefore be 24 minus 12, or 12. Comparing the expected bicarbonate of 12 to the actual bicarbonate, which is also 12. We are within range, so we do not have another acid-base disorder. Final answer. Because the anion gap is elevated at 24, we can say patient has a high anion gap metabolic acidosis. Additionally, patient also has a concurrent respiratory alkalosis. The concurrent high gap metabolic acidosis and respiratory alkalosis in this patient with tinnitus is most likely due to salicylate intoxication. This is the case of a 26-year-old thin female who presents with weakness and fatigue. Step 1. Check serum bicarbonate. It is 36, which is high. This means we may have a metabolic alkalosis or respiratory acidosis with renal compensation. Step 2. Check pH. pH is greater than 7.4. This means the most likely disorder is metabolic alkalosis. Step 3. Check compensation. For metabolic alkalosis, every 1 increase in bicarbonate would result in an increase of 0.7 in PCO2. Since serum bicarbonate increases from the normal 24 to 36, or an increase of 12, the PCO2 should also increase by 12 times 0.7, or 8.4, or approximately 8. The expected PCO2 is therefore 40 plus 8, or 48 plus or minus 3. Comparing the expected PCO2 to the actual PCO2 of 46. This is within the range of 48 plus or minus 3. We are okay. No hidden process here. Step 4. Calculate serum anion gap. It is 13, which is within normal range. We are okay. No hidden process here. Final answer. Patient has a metabolic alkalosis. The metabolic alkalosis is likely due to vomiting in this young, thin female. Self-induced vomiting may be seen in patients who suffer from bulimia or anorexia. The clue here is her urine chloride is very low. This is consistent with volume depletion associated with vomiting. Metabolic alkalosis associated with hypovolemia may be corrected by administering sodium chloride solutions. Delivery of chloride to the collecting tubules allow for bicarbonate secretion into the lumen for excretion in exchange for the reabsorption of chloride. Because this form of metabolic alkalosis can be corrected with chloride infusion in the form of sodium chloride, it is also referred to as chloride-sensitive metabolic alkalosis. This is the case of a 56-year-old male with pancreatic carcinoma who presents with a dry cough for 3 days. Step 1. Check serum bicarbonate. It is 17, which is low. This means patient may have a metabolic acidosis or respiratory alkalosis with renal compensation. Step 2. Check pH. pH is 7.45, which is greater than 7.4. This means the most likely disorder is respiratory alkalosis. Step 3. Check compensation. For acute respiratory alkalosis, every 1 drop in PCO2 would result in a drop of 0.1 in bicarbonate, and for chronic respiratory alkalosis, every 1 drop in PCO2 would result in a drop of 0.5 in bicarbonate. Since PCO2 drops from the normal 40 to 25, or a total drop of 15. For acute respiratory alkalosis, bicarbonate should decrease by 15 times 0.1 or 1.5 or approximately 2. For chronic respiratory alkalosis, bicarbonate should decrease by 15 times 0.5 or 7.5 or approximately 8. The expected bicarbonate should therefore be in the range of 16 to 22 plus or minus 2. Comparing the expected bicarbonate to the actual bicarbonate of 17. 17 is within the expected range of bicarbonate. We are okay, no hidden process here. Step 4, calculate serum anion gap. It is 11, which is within the normal range. We are okay, no hidden process here. Final answer, patient has respiratory alkalosis. In this particular case, patient developed respiratory alkalosis from a pulmonary embolism. This is the case of a 65-year-old male with a history of chronic obstructive pulmonary disease who was admitted for acute decompensated heart failure with volume overload. Patient received aggressive diuresis with loop diuretic. Step 1, check serum bicarbonate. It is 35, which is high. This means patient may have a metabolic alkalosis or respiratory acidosis with renal compensation. Step 2, check pH. pH is 7.36, which is less than 7.4 or low. This means the most likely disorder is respiratory acidosis. Step 3, check compensation. For acute respiratory acidosis, every 1 increase in PCO2 would result in an increase of 0.1 in bicarbonate. And for chronic respiratory acidosis, every 1 increase in PCO2 would result in an increase of 0.4 in bicarbonate. Since PCO2 increases from the normal 40 to 59, or we can round it up to 60, we have an increase in PCO2 of 20. Bicarbonate should also increase by 20 times 0.1 or 2 for acute respiratory acidosis. For chronic respiratory acidosis, bicarbonate should increase by 20 times 0.4 or 8. The expected bicarbonate should therefore be in the range of 26 to 32 plus or minus 2. Comparing the expected bicarbonate to actual bicarbonate of 35. 35 is greater than the expected range of bicarbonate. This means patient also has a metabolic alkalosis. Step 4, calculate serum anion gap. It is 10, which is within normal range for anion gap. We are okay here, no hidden process. Final answer. Patient has respiratory acidosis and metabolic alkalosis. The chronic respiratory acidosis is most likely from COPD. The metabolic alkalosis is most likely from aggressive diuresis with loop diuretic. Note that aggressive diuresis with loop diuretics can lead to metabolic alkalosis with compensatory CO2 retention. This CO2 retention can worsen the existing CO2 retention from COPD. Severe CO2 retention can lead to CO2 narcosis and respiratory arrest. If more aggressive diuresis is needed for these patients, consider lowering the dose of loop diuretic and add acetazolamide to minimize the metabolic alkalosis associated with the use of loop diuretic. This is the case of a 32-year-old male who was brought in by paramedics after being found unconscious in his garage at home. Step 1, check serum bicarbonate. It is 12, which is low. This means patient may have a metabolic acidosis or respiratory alkalosis with renal compensation. Step 2, check pH. pH is less than 7.4. This means the most likely disorder is metabolic acidosis. Step 3, check compensation. For metabolic acidosis, every 1 drop in bicarbonate would result in a drop of 1 in PCO2. Since serum bicarbonate drops from the normal 24 to 12, or a total drop of 12, PCO2 should also drop by 12. The expected PCO2 is therefore 40 minus 12, or 28 plus or minus 3. Comparing the expected PCO2 to the actual PCO2 of 40, 40 is much greater than 28 plus or minus 3. This means we also have a respiratory acidosis. Step 4. Calculate serum anion gap. It is 31, which means we have 31 minus 12, or 19 extra anions or acids around. The 19 acids are expected to consume 19 bicarbonate and give us an expected bicarbonate of 5. Comparing the expected bicarbonate to the actual bicarbonate. The actual bicarbonate of 12 is greater than 5, so we also have a metabolic alkalosis. Final answer. Patient has a high anion gap metabolic acidosis, respiratory acidosis, and metabolic alkalosis. This is a triple acid-base disorder. Possible scenario is a patient with ingestion of toxic alcohol, such as methanol with formic acid as its metabolite, respiratory acidosis due to reduced respiratory drive from the toxic alcohol, and metabolic alkalosis from volume depletion with or without vomiting. Alternatively, this patient could have developed his high anion gap metabolic acidosis from ethylene glycol from drinking antifreeze. Ethylene glycol is metabolized to oxalate. Oxalate can precipitate as calcium oxalate crystals in the urine and cause kidney failure. This slide shows calcium oxalate crystals in a patient with ethylene glycol intoxication. Calcium oxalate crystals can resemble dumbbell shape, picket fence, or O and X as in oxalate shape. This is the case of an acutely ill woman with a history of nausea and vomiting who is admitted for lethargy. Step 1. Check serum bicarbonate. It is 24, which is normal. We don't know if there is any acid-base disorder here. Step 2. Check pH. pH is 7.4, which is normal. Nothing abnormal here. Step 3. Check compensation. No abnormal disorder so far, nothing to compensate. Step 4. Check serum anion gap. It is 21, which means we have 21 minus 12, or 9 extra anions, or 9 acids around. The high anion gap here gives us a clue that there is a high anion gap metabolic acidosis. The 9 acids are expected to consume 9 bicarbonate and give us an expected bicarbonate of 15. Compare the expected bicarbonate to the actual bicarbonate. The actual bicarbonate is 24, which is greater than 15. So we also have a concurrent metabolic alkalosis. Final answer. Patient has concurrent high anion gap metabolic acidosis and metabolic alkalosis. The two opposing disorders normalize the pH and serum bicarbonate. The only clue that we have in this problem is the elevated serum anion gap. A possible scenario is a patient with lactic acidosis from tissue hypoperfusion and volume depletion with or without vomiting. The end.